the treatment algorithm for women, primarily women with fecal incontinence. Yeah, the clicker is kind of... I think you've already learned that to understand that conservative approaches to the treatment of fecal incontinence are first line. You wouldn't just, if a woman came into your office, you do interstim, you wouldn't just start loading her up and getting her ready to go to the OR. I think all of us understand and appreciate that you need to partner with somebody that educates your patients regarding their pelvic floor, regarding their diet, as well as strategies. I believe this absolutely. And it's so nice to be partnered with colleagues that help me to achieve this in my patients. We hope to appreciate that the optimal treatment regimen may be a complex combination of various non-surgical and surgical approaches. And I hope to present evidence in case-based surgical treatment approaches for fecal incontinence today. So basically, I would just want to start off by stating that this is kind of a good Cochrane review to look at. There have been increasing innovative developments both in the surgical and non-surgical arenas regarding the treatment of fecal incontinence. The thing that's frustrating is that the way the data exists right now, it's really hard to compare outcomes across all these modalities. And why is this? Because there's different outcome measures being done, whether they're measuring as a primary outcome incontinence episodes versus quality of life, whether their incontinence is good, better, or not so good, as well as the time points at which these measurements are made. So I think the biggest take-home from Brown's Cochrane is that we really do need more larger, rigorous, randomized controlled trials, and I threw in the use of sham treatments as well, as that was very important in terms of looking at PTNS with FI. However, it should be recognized again, and I think by the end of this course you'll recognize that optimal treatment quite often needs a combination of both non-surgical and surgical intervention. So let's start off with a case. This is a typical patient I would see in my practice. 55-year-old female. She's para 3013. She has a 5-year history of fecal incontinence as well as anal rectal urgency. She describes incontinence of liquid, solid, stool, and gas despite a credible attempt at management with behavioral therapy, i.e. she's seen my colleagues in crime at the table. She's had 3 SVDs, largest infant weighing 3,700 grams. She had a first forceps delivery with a lot of stitches. She describes some alternating constipation and diarrhea. She is slightly obese and has had a cholecystectomy. So on physical examination, she's seen to have a decreased anal tone. She's got intact reflexes. You can see around the anal verge that there's a dovetail type appearance. Her perineal body seems to be about 2 centimeters in thickness. However, some of that seems to be redundant skin. She has reasonable isolation, decreased squeeze pressure activity, and good relaxation. And on anal manometry, she has a resting tone of 25 millimeters of mercury with a squeeze to 55, normal sensation, compliance of 200 cc's in a normal rare. An endoanal ultrasound revealed, as you see here, you can see the internal sphincter intact all the way around with a low disruption of the external sphincter. So this is probably the most common reason why a surgeon would see a woman with fecal incontinence, especially if she doesn't gain improvement with a behavioral therapy approach. And we all know that direct sphincter injury primarily results from obstetric injuries. However, there can also be injury due to anal rectal surgery or trauma. And you can see the dovetail, let's see, it's a kind of a classic thing for our residents, the dovetail appearance in the anal verge area. So just to be clear, the term sphincteroplasty as compared to primary sphincter repair, sphincteroplasty is used to describe a secondary or delayed reconstruction of the anal sphincter muscle, which has had either a previous repair that's maybe broken down, or perhaps she had a defect that was not repaired. So a defect that was not repaired or not repaired well. Among women, and this is some information from a childbirth and pelvic symptom study that was done through the Pelvic Floor Disorders Network, among women who had a sphincter tear repaired at the time of delivery, so recognized and repaired, 35% of these continued to have an internal anal sphincter gap, and of those women, the majority also had an external anal sphincter disruption, both at 6 and 12 months. So it's not such a far-fetched thing to consider that a woman that you may see in her 50s may actually have a sphincter repair. And as you know, when we do a sphincter repair, basically, again, and I used to have a video, but for time purposes, we had to take that out. You can see the dovetail type appearance here, and typically we make a semilunar incision around the anal verge and really dissect that out widely. Then we use a Metzenbaum scissor and kind of create sphincter pits, take an Alice and go in and grab sphincter ends both to the left and right. And typically you see that nice white capsule surrounding the sphincter muscle. That kind of helps you orient you that you've got the right stuff. And then, and obviously this isn't an optimal picture, but this cartoon shows the external anal sphincter being brought together. Typically when I do a sphincteroplasty, I use a 0 PDS, either 2 or 3, and we also try to get some internal anal sphincter together as well. And it's not easier to get the internal anal sphincter together when you do that semilunar approach on the anal verge area. So what is the outcome with respect to anal sphincteroplasty? The data reflects effectiveness in the short term. I think most of you probably appreciate this, where 70 to 80% of patients report symptom improvement. However, long-term success tends to deteriorate over time, with 20 to 67% success rates by 5 years, and anywhere from 0 to 40% at 10 years. Glasgow and Lowry had a nice systematic review of FI studies from 1991 to 2010. 16 studies met the selection criteria, had a combination of 900 patients, and in general, if you're looking at a proportion of patients with a, quote, good outcome, many of these studies were done retrospectively. So a lot of the outcome measures were very suspect, very subjective, and not with validated subjective measures. But you can see over time in many of these studies that patients go with good outcomes, and over a 10-year period of time go to a less good outcome. So in summary, about 2/3 of patients report improvement in their incontinence symptoms. Most of this data is based on patient recall because there's very little prospective, robust data looking at patients prospectively that have had sphincter repairs. Oftentimes, the outcome is defined by good, whatever that means. And really, it wasn't until the past 5 years where we really started to use standardized, validated questionnaires. Through looking at these studies, no big factor was significantly associated with a worse outcomes. For example, age, severity, duration, these types of things. I really do think it's still an appropriate first-line therapy for women with a major sphincter defect. To me, the repair of an anal sphincter really nicely fits an orthopedic model. So in that model, what do? You give a rotator cuff tear, you fix the tear, then you let it heal, and then you rehab to build strength and function. And that's where my colleagues come into play. So, and quite often, I'll have them do some prehab before their surgery. They'll kind of get an idea of how to isolate, start working on their diets, and hoping that they'll get better outcomes. And if anything, it restores the sphincter to a good circumferential configuration so they've got more muscle to work with, and it builds up the perineal body in a lot of women that just have sometimes a very thin perineal body. As you know, the most common complication of a sphincteroplasty is a wound infection. If you look at the literature, anywhere from about 2 to 35%. So just to complement the sphincteroplasty, obstetric anal sphincter injuries occur in up to 9% of deliveries, and up to 11% of premiparous women may have an occult defect. You know, it's still out there. overlapping versus end-to-end repairs. I'm kind of the idea, get as much overlap as you can in the muscle. But there's really not been a definitive trial that has told us or told the OBs to do end-to-end versus overlapping. And we know that women that have obstetric anal sphincter injuries are twice as likely to have postpartum fecal incontinence. In fact, we looked at recent data in over 300 women permiparous women that had an obstetric anal sphincter injury, and we found fecal incontinence symptoms ranging from 4 to about 9% at 6 to 24 weeks. Anal incontinence symptoms at 6 months was seen in 24% of subjects, and fecal urgency at 24 weeks in 21% of subjects. And as you know, fecal urgency is a modifiable risk factor. And so we need to really be more proactively getting these patients some help. Although on the other side of things, as Baruka has stated, often these patients are able to compensate, and they may not start having symptoms till they're several years out from this index injury. So this is back to kind of the lower end of Elaine's algorithm. So they're refractory to multi-component behavioral therapy. They maybe have had a sphincter repair, or maybe they don't have a torn sphincter. What else is available? We're going to go ahead and hit the next the case here, to start this discussion. So we've got a 67-year-old female with a 7-year history of fecal incontinence. She has incontinence of liquid solid stool 3 times per week, necessitating constant pad use. And she's scared to leave her home. She's homebound. She's had a sphincter repair. She's tried behavioral therapy, including pelvic muscle exercises, other PT strategies, so perhaps biofeedback. She pays attention to her diet. She's tried loperamide, some improvement, but there's still room for improvement. A recent 2-week diary revealed nearly daily bowel movements with leakage 2 times during the first week and 3 times during week 2. She's got a history of hypertension. She's had a previous hysterectomy. Physical examination revealed decrease in erectile tone. She had intact reflexes. She has reasonably good isolation of her pelvic floor muscles, good squeeze pressure activity. She's able to relax well. She was seen to have a resting anal tone of 40 millimeters of mercury with a squeeze to 70. Normal sensation, compliance a little bit reduced at 100 cc's, and a normal rectoanal inhibitory reflex. And an end-anal ultrasound revealed an intact internal and external anal sphincter. And she's considering colostomy, so she's talked with the colorectal surgeons. What other surgical options are available? Of course, many of us now, anybody here doing sacral nerve stim for FI? Awesome. So we know that there's very many potential neurologic targets, including voluntary somatic, afferent sensory, and efferent autonomic neurotargets for this treatment. There's been a study that has shown rectal blood flow has increased after the use of sacral nerve stimulation. But I think in general, overall, what we're seeing with this modality is decreased episodes of spontaneous sphincter relaxation, along with an interruption of the constant sensory input to the rectum by the modulation of neural reflexes. So I do a stage testing. I don't do an in-office PNE. I do a stage testing, but this is done after she's done a 2-week bowel diary. As you know, this is an outpatient procedure. Just as with using InterStim for refractory OAB, you're shooting for S3 foramen. So this is, you have the fluoroscope in the room with you to make sure you get good placement. And they're not totally asleep, they're sedated. You want them to be able to respond to a pulling or feeling down in the vaginal area and the perianal pull, which happens as well as you're looking for toe flexion. So after she's a successful implant, we do another 2 to 4 week diary. If she has a 50% decrease in fecal incontinence episodes, I'd then move to a stage 2. So show me the data. Previously, and I think in your handouts, I may have had a series of tables, and I've just kind of distilled this down, looking at short-term outcomes defined as less than 12 months, medium-term outcomes 12 to 36 months, and long-term outcomes greater than 36 months. Success rates by ITT range from 63% short-term, 58% medium, and 54% long-term. But if you look at per protocol or those patients that are successfully implanted, you see that the success rates are around the 80% range, both short and long-term. And there's even some evidence of increased and sustained benefit over 10 years. Okay, of course we have to be aware of the potential adverse events. Most of these occur within the first year of implantation. Common events include device pain and paresthesias. You hate when they describe getting shocks down their legs or all these other things that you hear. A recent meta-analysis, however, has reported a much lower rate of implant site pain than there used to be. It really has become, with the tined leads approach, has become much less invasive. And explantation rates are probably in general less than 5%. And infection rates are pretty low as well. And I don't know about you all, but they go home first stage with 2 weeks antibiotics. And after second stage, I also give them antibiotics. Try and stay away from the antibiotics that give diarrhea, of course. All right, let's look at look at artificial sphincters. So the artificial bowel sphincter has actually been around for a while. As you know, this involves the implantation of an inflatable cuff around the anal canal. This cuff is connected to a pressure regulating balloon that's in the prevesical space, and it's all joined together by a pump that's placed in the labia. So the woman is able to pump up the anal cuff in order to keep bowel movements from occurring, and deflates the cuff when she wants to have a bowel movement. As you know, success rates vary greatly. Again, it's hard to compare when you've got different types of outcome measures being done or at different time periods. But in general, I think most people would agree that success rates range from about 50 to 77%. However, these success rates are somewhat offset by complications. And the most common reason for revision is micropore leakage from the cuff because of cuff fatigue from constant increased cuff up and cuff down. The most common reason for explantation of the artificial bowel sphincter is erosion, and you can see this occurs in anywhere from about 6% to 25% of studies of patients, and infection rates that range anywhere from 4 to about 60%. And I've really been kind of biased by this. Early on, we had a colorectal surgeon that I'd seen one of these done, and it wasn't really very pretty. Now, more exciting and more recently is the use of the anal sling. And this is data that was presented to Society of Gynecologic Surgeons in March, and I believe is also being presented here as well. So anal slings, just like the urinary slings for the treatment of stress incontinence, have kind of evolved. They've evolved in terms of the use of materials that have been used. As you can see, there's some pretty inflammatory materials there that we know are bad for the pelvic floor. Some of these materials causing big-time infections, sinus tracts, and that. But of course, we've found polypropylene, which is relatively inert and is really hard to infect. So this is the Topaz sling that was used. This is a study that was sponsored by AMS called the Transform study. It was a prospective multi-center study, single-arm, open-label, 2-stage adaptive study with one planned interim analysis. The primary outcome was obtained from a 14-day bowel diary and was defined as a 50% reduction in fecal incontinence episodes. They had 152 women that completed, where we got results at 12 months. And this mesh sling is placed by a transobturator approach. I'll show you that in a second. So the primary outcome for this trial, 50% reduction in the number of FI episodes from baseline at 12 months on a 14-day bowel diary. Important secondary outcomes included decreases in fecal incontinence days and urgency, symptom severity, quality of life, as well as safety. which is obviously number one on everybody's radar. So really the measuring out is very, very similar to those of you that may have done ProLifts in the past. You measure over 2 centimeters lateral, 3 centimeters down, and then you have puncture sites 5 centimeters across. And this is actually in the area, the idea is that this sling is shoring up the puborectalis muscle. So you can see, let me go back one. So you can see you take a Coker or Kelly clamp in between, you bring the sling through, and then you go from your transobturar approach, and with the device as seen here, goes down lateral of the labia, comes down into the area where you've come through, and you bring the sling up. So in this study, the mean age of these patients was 60. Mean BMI was 27, so overweight. The majority were Caucasian, and the majority were postmenopausal. Mean surgical time was 33 minutes. Estimated blood loss mean was very low. Mean hospital stay, this was really targeted as an outpatient procedure, and there was no described visceral injuries or perforations. So the primary outcome at 12 months, there was a 69% success rate. So 69% of patients had a greater than or equal to 50% reduction in fecal incontinence episodes. And you actually really saw, 65, it stayed pretty steady from 3 months to 12 months. And along with that, you see a significant decrease in median weekly fecal incontinence episodes, where you see them go from a median of 9 down to 2. There was also significant improvements in the Wexner scale, a significant decrease in fecal incontinence days, as well as fecal incontinence with urgency. When we obviously were have a heightened awareness about the use of mesh in the pelvis and adverse events. The most common adverse event was pelvic pain with 47 episodes. 17 ended up resolving without treatment. 29 were treated medically. There was 1 described sciatica surgery. 10 had persistent pain in a year. But none of these were classified as serious adverse events by FDA standards. And there were no erosions or extrusions of the mesh, which is important. And that's out to a year. So we've gone from artificial sphincter, anal sling, which is still investigational. The anal sling hasn't been FDA approved yet. Let's go to some other treatment modalities. Anybody here use the SECA? So the SECA is a 4-quadrant nickel titanium electrode deployment that in theory is supposed to be deployed into the submucosal area of the internal anal sphincter. Radio frequency energy goes through these electrodes, achieving temperatures of 65 to 85 degrees Celsius, and essentially resulting in denaturation of the underlying muscle and connective tissue, and effectively causing a stricture down in this area. And a similar procedure such as this is done for gastroesophageal reflux. So what's the data for SECA? Again, I think I had a table in your notes. I kind of distilled it down to really the long-term efficacy data, where you see this is a 5-year study where you see a significant improvement on the Wexner. 80% of subjects had a 50% improvement in incontinence episodes, but this is an N of 19 patients. The other studies that are in those tables reflect Ns of anywhere to 8 to 50. And there's no comparative data with the SECA with any other treatment modality, which is difficult to, kind of understand. The main adverse effects with the SECA is rectal bleeding and pain. Dr. Markland did discuss the PTNS, so I won't go there again. She also discussed the hyaluronate sodium bulking, so we won't be redundant there. Let's go into the real sexy magnetic anal sphincter. This is still investigational per report. It's easy to implant around the anal canal, called the Phoenix. It's a series of titanium beads that are linked with independent titanium wires. These beads have a magnet, so these beads baseline are together and kind of close off the anal canal. And then my understanding is with a Valsalva that a certain threshold is reached and the beads then separate and bowel movements are able to occur. So in the study that I've seen, 18 subjects, 15 of them women, underwent the magnetic anal sphincter. Follow-up in these patients was 1 to 2 years. You see a significant reduction in the Cleveland Clinic or Wexner score, and there were also significant improvements in the FIQOL. And almost 80% of subjects had a greater than equal to 50% reduction of FI episodes. Again, this is investigational, but who knows, maybe next year we'll hear something more. And certainly there is some investigational studies being done with autologous myoblast injection. And the idea here is that the myoblast will be placed in the area of the anal sphincter that's injured and will replace or repair damaged sphincter muscle. Animal studies have been done, and the myogenic stem cells are also being used in this area. So for final consideration, she's failed SECA, she's failed everything, she's failed a sling. Of course, many of the kind of new developments aren't out there yet, so they're not accessible to us. But really a final consideration, I think, is fecal diversion or colostomy. There are actually one case-controlled, 2 cohort studies that do describe improvement in quality of life after colostomy for refractory fecal incontinence. It's supposed to be more cost-effective at 5 years than the use of the artificial sphincter. Usually this is an end-sigmoid colostomy. However, we were talking yesterday that we have seen some patients that have an ileostomy, and that creates further things that need to be managed that are quite frustrating to the patient. So you should always have a good idea of what your colorectal surgeon is going to do. So in conclusion, I think we all know that the cause of fecal incontinence is often multifactorial. And as it's multifactorial, we have to partner with our multidisciplinary team to try and optimize treatment of this condition in our patient. First line and accepted therapy is education, pelvic floor muscle exercises, often with biofeedback, the use of medications, normalization of stool consistency and bowel habits. And what's exciting is the use of devices that are coming out. That can really be a stopgap for some patients while they're doing their behavioral therapy with biofeedback. And surgery may be helpful for many women. The bottom line is we need to be able to discuss all options with our patients and individualize care. I'd also like to say I personally think sphincteroplasty still has a role. I think we need to just look at it, now that we're in the age of good, robust, objective and subjective outcome measures and time points. I think we do need to relook at this. I think neuromodulation is an exciting treatment modality for those patients that still have room for improvement after a credible behavioral therapy. And I think it's going to be neat to see some head-to-head data on the use of devices for some of these other treatment modalities. And if you think you've had a bad day, things could always be worse. So thank you for your attention. It's been great, and we're here to answer any questions.
Hi, Marie-André Harvey from Kingston, Ontario. Thank you for your great presentation, very informative. I was wondering, at one point in time before doing sphincteroplasty, there was a discussion on assessing integrity of the innervation with the pudendal nerve motor latencies or EMG studies. What's the role of that now?
Yeah, that's a very good question. So the question is, before doing anal sphincteroplasty, you want to assess innervation. The problem there is, even if you have an abnormal pudendal nerve terminal motor latency, it's only measuring what if that's normal? You still have slow fibers that may be abnormal. So to my mind, I don't do any kind of innervation testing before a sphincteroplasty. What I try and do is get them to these guys, at least so that they can somewhat learn some strategies to help them, but I definitely get them there after surgery. And I think biofeedback I think would be a very helpful modality for these patients. Great question.
Hi, I'm Jay Alario from Boston, US. Can you comment on the ideal setting where one could implement a program providing behavioral therapy, and because there is low reimbursement, as we know, in the U.S., and this has discouraged people from doing much about that.
Yeah, a basic behavioral therapy program can be implemented in a primary care clinic if you had somebody interested. I mean, we're geriatricians, and we started one in our geriatric clinic. And you can be very low tech, and you can bill for, at least in the United States, you can bill for the time, just a regular visit without billing for the procedure. And because there's widely different coverage and who covers which procedure. But to do dietary management, medications, along with the physical therapy, teaching them strengthening and control mechanisms, you can have some really, really good results and still get reimbursed decently and do okay in your clinic. Even if they won't pay for biofeedback, sometimes we do it anyway. Just charge for the time of the visit.
Yeah, I definitely agree. I mean, it's a problem in the U.S. with the biofeedback not being paid for, despite trying to reapproach the insurance and go through the red tape and all the paperwork that goes with that. I will just add that, sometimes we also send out to physical therapy colleagues in the community or at your institution who specialize in this. Now, not all physical therapists or physiotherapists have specialized training for biofeedback and or pelvic floor, but the ones that do are fabulous, and that can be covered from a physical therapy benefit from most insurance. So we tend to be more nurse practitioner based in our current practice care model, but I definitely think there's a role for physical therapy as well.
My question, I guess I should be honest, is more of a personal, selfish question. I was born with a high and perforate anus, so without a sphincter, and had a Lassiter sling done about 30 years ago that was unsuccessful. Have you ever seen a patient that has gone back to try to redo a Lassiter sling that has been successful?
No, that's a very intriguing question. I have not seen that. I've not seen that, and I'm wondering. So, what are you having issues, or?
Almost certainly, yeah.
Yeah.
I'm basically chronically fecal incontinent, daily.
Yeah.
So I obviously wear protection.
Sure.
On a list for an artificial sphincter, but I'm about 13th on that list, and they don't do too many here in Canada.
Yeah, and they're doing less and less in the U.S. as well. It seems like for the condition that you have, you may get some great benefit with that. So I hope you move up.
Magnetic sphincter, too. It sounds really promising if it comes in.
It does. I mean, and that's something that's a little more physiologic in terms of being activated with a Valsalva rather than having to, use the pump type thing.
And I will say, I just echo, there are new and emerging treatments coming out. I mean, I know this is an awful problem, but some of the the silicone anal type plugs are actually really well tolerated and were tested in men and women. And so a lot of the evidence we presented today would exclude someone like yourself from a clinical trial. But some, and I hate to say, some of the containment might be a bridge until something else can become available. And so it's not a fix, it's a containment.
Sorry, I'm Louise Perman, physiotherapist. Aren't the anal plug supposed to be used when you have no sensation, like for paraplegics, or you can still use it? Yeah. Okay. 'Cause I thought it would be like irritating and no.
From my understanding, there are system reservoir type systems
Okay. And
versus the plugs.
Okay.
Yeah,
All
so
right.
there's two types of
Okay. I
things.
have another question. In terms of products used in medication like loperamide and the other ones, what about long-term use of that? Because I'm concerned.
No problem. I mean, you go into the drugstore and you buy loperamide, and it says
but
don't use it more than X amount of times. But
Yeah.
once your physician's prescribed, you can use it for months
But
and
what
years
about,
and years.
What about the other one that is the cholecyster? What's it called?
Cholestyramine too, you
Because
can
that
use
is
it.
changing the bile.
It's binding the bile acids, so people are on that for cholesterol reduction for years and
So
years
it
and
could
years.
be long-term.
It's very safe. Its main side effect is constipation, and you can fix that by adjusting the dose. So it's a
another
very
question.
safe medication for long-term use.
Okay. Can I have another question? Yeah. Okay. And so what about the women who have like a 4-degree tear when they deliver, and let's say they don't want any more babies? Let's put it this way. So how long should we wait? You know, after they have their, because you know there is some repair at the delivery,
Right.
but it's not usually like a, you know, application necessarily, and so.
So a 4th-degree repair at the time of delivery, I mean, that's put together primarily. So the anal rectal mucosa is repaired, the sphincters are repaired, and so a time period until you start behavioral therapy, I don't know, what do you think, 4 to 6 weeks, huh? Until it's, the pain goes
Okay,
down.
but very often also we see like 4-degree tear,
Yes.
no repair because it was partial. So we see them in therapy, you know, and it's because they don't have the symptoms now,
Yes.
but they will,
Yeah.
you know. So, and we see them in therapy, in physiotherapy, and we have some results, but no tests have been done. So how aggressive should I be sending them back and say, hey, we need some more testing? And
So for
it
sure-
won't work for enough. You know, she's 32,
Yes.
so she can't be like that forever.
Oh, yeah, no. If she's got a skin perineal body, you know the muscle's not together. I mean, you should call the referring doc and say, there's something, maybe we should do something else so that you can optimize your care of her.
Okay. All right, thank you.
Yeah, and I think, too, your question is, we don't quite know the optimal time to fix after an injury. And I think there'll be some people who would say you'd wait till after breastfeeding or, you know, hormonal, but no. Okay. Okay. Not for primary, but for further repair, like after the primary repair, but there's some period of waiting. But again, I don't think we actually have the evidence to really say one way or the other.
What I would say is if she were to want it right away, let's say she had a primary repair, it broke down, I would wait at least a minimum of 3 months before I would go back. Kind of let that inflammation and quite often the granulation tissue there from suture and that.
Hi, I was hoping that you could make a comment on, let's say, fecal incontinence due to neurogenic causes like incomplete spinal cord, where containment strategies may have failed and anal plugs not acceptable to patients. What are your, other than the investigational methods, what are your next steps?
Yeah, that's a really good point. We really didn't talk about that today. And, you know, I think the containment methods, there is some great evidence for the bowel evacuation systems out there for spinal cord injuries and people who really suffer from, you know, not just fecal incontinence, but constipation with nerve injuries. And we didn't talk about that. And I do think there's emerging treatments, evacuation systems. Currently, we have trouble getting those paid for in certain situations in the United States. Even though we know they exist, there's some evidence behind them. But again, I think there is a more proactive development going on, and we did not talk about that. So I hope that answered your question.
Yeah, and sometimes the injuries are partial, and we've had very good luck with biofeedback in retraining patients who still have some function. I mean, we've seen ambulatory patients that are ambulatory quads who can do really well with relearning with what they have left, and biofeedback can be really helpful for those cases. Also, the whole thing of manipulating stool consistency and, you know, everything else that we talked about. It's an excellent question.
Well, Jochem Veen from the Netherlands, gynecologist. In the Netherlands, we use quite often bowel washings. You have this peristain system, which is of course expensive, but that might be, I mean, if the women are really well trained, and they can really wash out the descending colon. That can help them out for about 2 days.
Yeah, and we.
Cheaper system.
Mm-hmm.
You can use just a stoma washout system, which is much cheaper than peristeen if the center is intact.
Mm-hmm.
And that's what I've been recommended for physiotherapists. Much cheaper
Yeah.
than peristeen.
So there are some cheaper options other than the peristeen ostomy washout. But when that fails, I think that's really a difficult situation. And I don't always have the answer to that. And it's kind of going to all the different contributing factors, looking at, you know. and managing from, sometimes multiple specialists.
Yeah, and a colostomy is a lot better than a totally incontinent anus, and it's a definitely very good lifestyle choice for the patients that fail everything else, and there's nothing else on the horizon for them.
I still have one more question about the workup for bulk injection. How do you select your patients?
Excuse me.
I think that's a great question. We typically would only do an injection at our center, in my opinion, when someone has failed multiple conservative treatments and had physiologic testing. And I also feel very strongly about anoscopy to look for hemorrhoids or other problems in the anal rectal area that would inhibit or stop you from doing an injection at that time. So very large hemorrhoids on anoscopy, those people were excluded from the clinical trials. So it's really important to really consider potential adverse effects in that area.
And does your workup also contain a anal ultrasound? And I mean, for me, it's always the question: how large should the gap be that you really might expect a beneficial response?
No, that's a good question, because quite often, if I've done an ultrasound on a woman with FI, and it's not that large a gap, I send her to these guys, and we can try that first before going and fixing that. In terms of when I do bulking, it's very similar to Elaine's. They've tried things. It's mainly those women that have passive type incontinence. Sometimes they'll have an IAS defect. And have you done it before? Have you done the bulking?
Well, my consultation is always together with a colorectal surgeon, and he does it.
Okay.
I'm
It's
not
pretty straight.
So satisfied.
Yeah, it's straightforward, but I would tell you, and I think they don't say it as overtly in the paper, but 80% of those people in the paper had a second injection. And I would agree with that anecdotally for my patients as well, that some may have a little benefit after one, but if they're going to have benefit, usually it's better after two. And it really is painless. I mean, it's a very straightforward procedure.
One quick clarification. I was wondering, listening to the behavioral modification, at one point you were talking about prompted voiding and decreasing, the attempt at decreasing fetal incontinence really having an impact on bowel movement. And I just want to clarify, we're talking about voiding and not prompted defecation?
Actually, a great question. I mean, I used the term, but I really referred to prompted defecation for this trial. The trial that was presented in the slides was prompted defecation, but the whole theory comes from prompted voiding, where prompted voiding showed an improvement in actually fecal incontinence as a secondary outcome in the studies that did it primarily for urinary incontinence in those very frail older nursing home populations. But in subsequent trials, they really did prompted defecation after meals, key time periods during the day, and even though it didn't improve fecal incontinence, you did have more continent bowel, or more bowel movements in the toilet and less constipation.